Thanks, Susan. And thank you to everybody who took some time off today to join us in chatting about cervical disease, PEMF and beyond, and the different things that we can look at when we're looking at treating these patients that have cervical problems. So we'll go ahead and get into it here. And we're going to do a little bit of a review to start with, let's look at cervical disease in general, because when we look at how do we treat something, we need to kind of review the disease itself so we can look at where we going to best target our therapies, what kind of compensatory issues we may see with cervical disease. So that's an important thing. So we see a lot of that. What modalities can we potentially use and how do we use those in treating our patients? What's out there? How are you going to manage these guys in your clinic when they come to you in various stages, from the dog with back who's walking fine and has neck pain to the dog that is non-ambulatory? And then what kind of at-home considerations do we need to look at as well? So that's kind of what the plan is for today. All right, so let's talk about cervical disease. And I always, of course, have to have my own animals in these pictures. So these are two of my dogs and their favorite pastime, which is tug of war. And hopefully Ruby here does not develop cervical disease at some point, because she would be very sad about having to give this up. So anatomy, one of those things that I always thought about in school as a, necessary evil, but actually not as much once we've been in practice and realize how very, very important it is, especially when we're looking at localizing our lesion and how we're going to treat these patients. So this chart, I think, is when I oftentimes, if I get myself in the weeds of trying to localize where in the heck my lesion is at, this one seems to just really help in looking at, where are we talking about here? Where's this spinal lesion? So remember that when we're talking about anything from C1 to, really to T2, but C1 to C6, that's kind of our thought. But we kind of put that C6 to T2 area, I'm going to lump in there as well, because that's our cervical intumescence. And when we're dealing with anything from C1 to T2, we could be dealing with tetraparesis or plegia. We could be dealing with just pain, right? We could also be dealing with a forelimb lameness. So we could have lower motor neuron to one leg, one forelimb, because maybe we have a lateralized disc, or we have a nerve root injury, or brachial plexus injury, or a neoplasia, right? So, and in those cases, the hind limbs could be normal, right? So just kind of keep those things in kind of in your mind. So when we look at the patients who get cervical disease, right? So there are definitely some breeds we see that are more prone to developing cervical diseases, and we'll talk about those. We have some that we're definitely going to see more likely have, say, intervertebral disc disease of the cervical spine. And then we're going to talk about, of course, wobblers. We've got certain breeds that are going to be predisposed to that. But it can happen in any dog, right? Any patient dog. I guess we could also say other species, of course, but this is we're primarily looking at the canine patient here. So symptoms, I think this picture really, this picture, you can look at this dog and say, yeah, this dog has cervical pain. We've got a low head carriage. They also, you can notice, are having a nerve root signature there on the right forelimb. This dog is definitely, we've got that going on. This one is not as hard to look at and say, oh, this dog looks like its neck might hurt, right? But some are maybe not as easy to figure out. But generally, we may see a low head carriage. We always say, if the dog is looking at you, if you're trying to get the dog to look at you and its eyes look at you, but its head does not follow, that might be that the neck is bothering it. Short-strided, you may have ataxia, two-engine gait, so that would be the short and choppy in the front and long and lopey in the back, because we've got that lower motor. It's more lower motor to the front and upper motor neuron to the back, which we see with the C6 to T2 lesion. Pain and vocalization. So pain may oftentimes be the only symptom that we're seeing, right? So pain can be the only symptom, and they could neurologically otherwise be normal. Paresis to paralysis. I've seen dogs with muscle fasciculations of their cervical muscles, and then I also see these guys oftentimes have myofascial trigger points, which we'll discuss. And then again, that forelimb lameness can sometimes present as a cervical injury, or cervical pain can present as a forelimb lameness. This does not mean that you shouldn't rule out other causes of forelimb lameness, but just remember to have it in the back of your mind, as that could be a contributing factor. So what kind of cervical conditions do we see? And so when we think of the spine, we think of intervertebral disc disease as being the most common. And so we definitely can see that in the cervical spine. But then we also have these non-surgical, generally non-compressive lesions that will go in a little more detail and description of FCE, ANNPE, and HNPE. And so we'll go into those a little bit. Of course, our wobblers, right? So our cervical spondylomyelopathies. And then we have this other category that I'll mention that kind of lumps the others. But the top three here categories are kind of our most common that we think of. So when we look at cervical intervertebral disc disease, we're looking at, most commonly, pain is going to be our number one symptom. And I would say, when I look at the spine and to have dogs come in with pain from intervertebral disc disease, they generally are more severe when it's cervical. I mean, yes, absolutely can be severe in the thoracolumbar area as well, but boy, these neck dogs just seem so uncomfortable. So that is oftentimes the number one symptom. It's often severe, and it may have a nerve root signature, right? So it may refer down one limb more than the other. Again, low head carriage, neck carriage, rigidity, muscle spasms, reluctance to move the head right in different directions. May have tetraparesis, hemiplegia, depending on if it's lateralized, or tetraplegia, which I would say is much less common to have tetraplegia, and of course, a much poorer prognosis, right? Because if that lesion is cranial enough, we're going to affect the respiratory centers and have much higher mortality. So luckily, we don't see that as commonly. It's more paresis than the plegia. And then, of course, you have your Hansen's type 1 discs, where you have actually an extrusion, and that's what we think of when we think of our dachshunds. And then we have our type 2, which is our large breeds, which can include our wobblers, and those are going to be more of our protrusion, right? So we have that demonstrated here in our slide. So with A with extrusion and B with the protrusion. So what about the wobbler, right? So wobbler syndrome, cervical spondylomyelopathy. Here's a poster child, one of the poster childs for this. These are usually large to giant breed dogs. And then, of course, there's variable forms, and this depends on the neurologist you talk to. I have one of my neurologists says, I just like to say, it's wobblers, right? And then there's different ways it presents. But if you read the literature, they do divvy them out, which I'll talk about here in a minute. So I kind of look at, we have Dobermans, and then we have everybody else, is kind of the way it usually looks. And those Dobermans are usually middle to older age when we are seeing more of their symptoms, versus the large breed dogs like our Great Danes. We're going to see those guys younger typically. And then clinical symptoms, generally more severe in the hind limbs. And this can be ataxia that then eventually progresses to tetraparesis. And again, if it's a C6 to T2 lesion, we may get that 2-engine gait. Cervical pain will be a little bit more variable with these guys, and how much pain that they have. They can absolutely have pain, but it will vary in severity, I find. And then we have our conservative versus our surgical management. And I would say that seeing what cases I see here and talking with my neurologist, that most of our cases are actually managed conservatively, because surgery definitely has its risks. And if you read in the literature, the success rate of surgery can range from, say, 30% to 80%. And so there's no consensus on which way is actually best to treat. And generally, when we're looking at surgery, it is to stabilize the vertebrae and reduce compression that then would cause instability kind of down the chain, right? And so there's long-term studies are lacking on that. But when we have a 33 to 80% success rate with conservative, it's kind of all over the place, right? So this is always a tough one, and I think very individual with the patient, the client, your neurologist, to kind of what you're doing. But most of the time, right, we're going to be seeing these guys and dealing with them in a conservative manner. So when we look at the difference between the two as a review, so we have a Doberman, which is the disc-associated or DAWS form. And so you have this high incidence of disc degeneration, foraminal stenosis, and asymptomatic spinal cord compression, typically asymptomatic. You can absolutely have symptomatic as well. You get vertebral malformations that lead to this malarticulation and instability, hypertrophy of the spinal ligaments, so the inner arcuate and dorsal longitudinal ligaments. You get a type 2 disc protrusion, and then an MRI will reveal oftentimes a dynamic compression or lesion, versus in the Great Danes and other large breeds, it's more of an osseous or bony um, form. And so some have actually considered this a form of OCD, so osteochondrosis dissecans. It may be the form of that. So you get dorsal and dorsolateral compression secondary to this arthritis of those articular processes, hypertrophy of the joint capsule and the interarcuate ligament. And then large heads too may exert more force on the mid to caudal cervical regions, which is maybe what partially predisposes these breeds to that. There's been even some postulation that how we've bred, like say the Danes, to get this distinctive gait when they're showing, did that actually that kind of breed in a little bit more of this, because maybe that gait's actually a little bit neurologic. There, I read that in a paper, and I thought that was kind of an interesting thought. You can also see extradural cysts can happen in these large breeds, and they're more common in Danes and Mastiffs, but can happen in other large breeds as well. And so they can have similar symptoms, and some of these can be non-painful even, but they'll have some neurologic symptoms. So when we look at how this looks like here, just as a review, I think pictures always make things a lot more sense. So on our top picture here, we have our disc associated. So in A is normal. B here, you can see that there is some ventral compression that's occurring in this picture. And then we also have by this hypertrophied ligament. And then in C, we have an asymmetric intervertebral disc protrusion causing compression of the spinal roots here, the spinal cord and nerve root. And then below, we have our osseous or bony changes. And so we have B actually is our normal here, but in A, you can see that we've got this severe dorsolateral spinal cord compression. This is at C23, and that is due to that osseous malformation there and arthritic changes. And then when we get down here to see 4-5, we have osteoarthritic changes bilaterally that's causing compression on these nerve roots as they exit here. So this is kind of what we're looking at in these different scenarios. So what about the non-surgical? Because we're gonna see these two, and they can be anywhere in the spine, but we do see it also affect the cervical. So we have our FCE, which is our fibrocartilaginous emboli. And normally these are more caudal lumbar, but the second most common site is mid to caudal cervical. All right. So these probably originate from an intervertebral disc. Material breaks off, enters the cord into via the arteries and veins, and causes ischemia to the cord. So this is what we would think of as a spinal stroke. That's one of the other terms we'll often use. Large breed patients are more common, and for some reason, mini schnauzers. So we'll see it in the schnauzers as well. And these are typically may have a history of exercise or playing, and then suddenly, go down. Right? There may be a vocalization and then go down. Not always, but sometimes there is. It's acute onset. It's generally non-progressive, especially after the first 24 hours. They're generally not painful after that initial thing, and it often is asymmetric. So usually one side's going to be worse than the other. An ANNPE, or an acute non-compressive nucleus pulposus extrusion. So these are similar. They're often acute onset again, and these ones definitely have more of a history of a trauma or exercise beforehand. They're non-progressive, asymmetric in many cases, and you may have pain initially, but that usually resolves. And this I have older large breed, especially border collies. And it's interesting, we recently had one in the hospital here that was a mastiff that was it was a puppy, And this is the second ANNPE I've seen in a young Mastiff under a year of age. So I think we're going to be seeing maybe the literature's changing with that, but historically, this is what is out there. And actually, cervical is the #1 site. So C1 to C5 is the #1 site, but you can again have these anywhere. And what happens with these is your nucleus pulposus extrudes with a force that causes a contusive injury, but no compression. So it's kind of a bruise. I always think of it as the disc comes through and punches the spinal cord and then goes back down. And so you get this non-progression after 24 hours with these guys. And so and they're more likely to have that vocalization that happens and some spinal hyperesthesia initially, but then resolves. HNPE, so these are a little more interesting. These are a hydrated nucleus pulposus extrusion. So some amount of a well-hydrated gelatinous extradural material can be identified in the vertebral canal with some varying degree of compression. But what they found with these is that surgery versus conservative management, there's been no data to say one is better than the other. And so you can do surgery, and they sometimes will, but oftentimes your conservative management has the same outcome. And so we typically hear most of these end up being conservatively managed. Again, acute onset, sorry. More commonly, these are going to be symmetrical in presentation, may or may not have pain, but yeah, oftentimes not as painful as a traditional disc. No history of exercise. Cervical is the most common site as well for this. And I would say generally the symptoms are going to be more severe because we can have actual compression on the cord in these guys. And they can affect any breed size, but oftentimes they're in older patients. So just as kind of, again, pictures, we've got here on the left kind of an example of, this is an FCE. So this little piece is coming up here, and it's gonna go ahead and cause an occlusion of this, artery vein, and cause this, kind of area of the stroke to the cord here. And then on our MRI, on our imaging, we often see these as hyper intense lesions above the disc. So that's like when we look at the criteria for diagnosing an ANNPE, it's this hyperintense lesion above the disc with reduced volume in the nucleus pulposus and maybe a small volume of extruded material above the disc, maybe some narrowing in the disc space, but no real compression on the spinal cord. So that is, and it's tough because of course you really can't differentiate these a lot of times unless you have imaging. And even then, sometimes they can be tricky to differentiate. And then lastly, what else do we have, right? So those are the most common things, but remember, we definitely can have neoplasia that affects the cervical region. Discospondilitis, not a super common area for it, but it could occur here. Immune-mediated polyarthropathy, these are joints. So we could have it affect the joints of the spine as well. Now, again, not maybe as common, but that can happen. Fractures, we can absolutely see cervical fractures, and then AA subluxation. All right, so we talked about our primary issues we see. Let's talk a little bit about compensatory and long-term issues with these cervical patients. So one of the big things we talked about was pain, right? So pain is so important. It's so critical with these patients. We see this pain, and this is definitely something, the #1 thing we need to address is the pain, because if we're going to see problem, we could absolutely develop a maladaptive or wind up pain. And oftentimes by the time these patients, I've seen them, they have some component of wind up pain already happening, and they're not responding to the typical drugs. They're having just these screaming events, and they're just so uncomfortable, and they've got this wind up going. And this can vary, from anywhere from a chronic low grade wind up, low grade, to hyperesthesia to allodynia. So we definitely want to address this. And although we're not discussing pharmaceuticals today, we absolutely 100% need our pharmaceuticals. So all these things are kind of multimodal management, right? And drugs are a very important part of this. So I use a combination of, I mean, it depends on the patient, right? Of course, because if they've got comorbidities, what are we going to use? But I will look at, well, opioids, NSAIDs versus steroids. There's debate there. That depends. We can go probably along talking to that, but we won't. But both of them can be used, not together, of course, but they're important to use in these guys. Muscle relaxants, I like those. Gabapentin or pregabalin, I am now more of a pregabalin person. I tend to reach for pregabalin more than gabapentin, but you can still absolutely use gabapentin. For our chronic ones, we can use amantadine. One thing when using amantadine, just realize that it does take some time to kick in, so you're not going to see effects with it for the very much effect for the first few weeks of that. So, you might want to go ahead and get it started, but just know it's going to take a little time. I use low dose ketamine, so all these different things, right? So they're very, very important. Next, we'll see myofascial trigger points, which I'll describe here in the next slide. But I definitely see these as, and these are usually compensatory things again, and I see them a lot in the cervical muscles and then the muscles of the forelimbs, especially around the shoulders as they're compensating. So in the triceps, lats, rhomboids, trapezius, all those things. We can then see decreased mobility of the forelimbs. So whether this is because we actually like our we call scapular glide. So the muscles all around the scapula are tense and tight, and we're because they've been either protecting their neck or they've got that two-engine gait, and so we've not been striding out properly, and we've got these tight muscles, and we get decreased shoulder and elbow range of motion, especially chronic wobblers. We see that a lot in decreased muscle flexibility, and then anything, of course, that flares up the front end, if you have pre-existing hind end area and inner problems, you're either going to potentially make those worse because you're shifting more weight to the back because the neck's bothering them, or hind end issues might flare up chronic cervical issues, right? So we can have that combination patient that we can see one thing flares up another because, of course, everything's connected, right? So what's a trigger point? A myofascial trigger point. These are hyper irritable spots in a skeletal muscle. So a palpable nodule in a top band of muscle fibers or fascia. And these, not always, but a lot of times when we palpate these, we get a twitch response, right? And it's repeatable. And these can cause both local and referred pain. And so they do often describe these in people as either active or latent. Active being that they are actually causing pain at all times and they can be causing referred pain, versus latent being they may only cause pain when we actually apply pressure to them. And they can contribute to chronic pain syndrome. So any of you, like me, gets tension headaches, those are oftentimes due to trigger points in our cervical area, in our trapezius, with referred pain up into our head. So oftentimes we have that going on, and this is one of the examples of of how that can happen. So that getting that compensatory type thing. So where do we see these at here? So we get our brachiocephalicus, that's our red here. So brachiocephalicus is one area we can see these in. We've got our omotransversarius in the yellow. We've got our trapezius in the green, but also the rhomboids underneath that. And then the blue, we've got our triceps here, and but deeper to that is the teres. So these are all areas where I'll a lot of times find trigger points. You can absolutely have them other places as well, but these are some of the more common areas that I encounter them, especially when dealing with forelimb or cervical problems. All right, so we've reviewed our anatomy, reviewed our conditions, looked at our compensatory things, talked about all that. So now, what are we going to do with these patients, right? Um, I'm going to talk about some of the more common modalities that I reach for or use, but this is not an exclusive list. I mean, there are many other things that can be done. We do not have time to talk about all of the things, so I'm just going to hit some of the big things. So just know that there are other things out there to consider, but we're just going to talk about these today in a little bit more detail. So when we're deciding what modality or therapy or what are we going to use? What tool in our toolbox do we want to pick for our patient? We have a couple things we need to consider, right? So what are your treatment goals, right? Is it pain? Is it improving mobility? Is it like, are they, predic, um, functional goals? Does the owner need him to do? We need to get him up to go outside and go to the bathroom. They need to be able to eat, the daily activities of living, as they would describe for us when we're having stuff done. The same things we got to look at for our patients, right? So what are our treatment goals, and how is that then tool going to help with that? What do you have available in your clinic? What do you have available that you can do, or do you have somebody that you can refer to near you? What do you have in your area? Is this on an inpatient or an outpatient basis? And if it is on an outpatient basis, some of the things you have to consider is how often can that owner bring the dog in? Can they transport the patient? Is it ambulatory? What's the size? What are their finances? Right, you have all those considerations you have to look at. What will the patient tolerate? I think that's always a very important thing to consider, because, I may say, oh my gosh, I absolutely want to acupuncture this patient. And this patient's like, no way in heck, I'm going to bite your face off. I'm not going to let you put any needles in me. So now what do I got to do? Right. And now they're painful on top of that. So now their aggression and their anxiety is amped up even more. So consider that one of the big things too is when a we see an increase in aggression, anxiety, things could oftentimes be a pain component. And so those things can be worse than when we've got this going on. Any contraindications or precautions do we need to worry about? It's always something we need. We don't do no harm, right? And then remembering multimodal is best, right? That is going to be our best option, is kind of a combination of ways to approach this. So let's talk about PEMF to start off with. So pulse electromagnetic field therapy. This is a magnetic pulse, right? That is inducing electrical chemical changes in the tissues to increase blood flow and modulate inflammation, which I'll go in a little more detail here in the next slide. But when these were first created, the main therapeutic purpose was to enhance the healing of bone and tissue healing, and then also pain control. They were introduced initially in the late 70s and approved by the FDA as bone growth stimulators. So that's what we did initially, but now we're using them for many different reasons. Um, these are loops or beds, oftentimes, is how they'll come. I mean, there are other on the large animal size, there's big paddles and waves and all these different things, but you've got to have you've got to have a way that the magnetic signal is being produced, and then you've got to have a coil that it then is produced within. So there's going to be a loop of some type usually involved. These can be used in clinic or at home by the owner. So you've got some flexibility there. They're very well tolerated, but you do need to use them multiple times a day is ideal. And then you can taper over time. And they're very safe, which is really nice. There's very, very few, if any, precautions or contraindications. The biggest thing being, whenever I'm going to use this with a client present or talk to an owner, one, I need to make sure my patient doesn't have a pacemaker, and does my owner have a pacemaker. Out of abundance of caution, we usually are going to say we need to keep those within a certain distance. Talk to your company about how far away from a pacemaker. But other than that, they're pretty darn safe. So what are we doing? We're doing this is creating vasodilation, increasing circulation and angiogenesis, which is going to modulate inflammation. And that is by an increase in nitric oxide. So that electrical chemical change that's being induced by our magnetic field is due to an regulation of calcium to calmodulin binding, which a byproduct is going to be increased nitric oxide, right? And increased cyclic GMP. So those things then cause these effects. We'll see a down regulation of interleukin 6 and tumor necrosis factor alpha. This is going to help decrease pain and inflammation again, which is great. There's also seen an increased expression of adenosine receptors in tissues, which we see with that a reduction of prostaglandins and inflammatory cytokines. And then they have seen also in studies modulation of metalloproteinase activity, which is going to improve chondroblast health and osteoblast activity in our arthritic patients. So these are all different things that have been seen that we know, but we definitely, again, if we're looking at decreasing pain, modulating inflammation, and speeding healing, potentially PEMF is going to be potentially beneficial for these guys. And the nice thing, of course, if you've got a loop, is it's very conveniently can be placed around most of our patients' necks. And so you can see in this picture, this patient of mine here, so one of my patients, she has every part of her has issues, but she had severe cervical pain, discomfort, or she did. She's better in this picture. She's actually looking at me. She wasn't looking at me for a while. She has laryngeal paralysis, and she also has two not great stifles and has had at least one TPLO, right? So combo patient, as we're looking at, and she does have this in clinic and at home. So what do we have for evidence, right? It's always the best that we have evidence for our for our patients and for what we're using our modalities for. So I kind of did a little dive on this, and for on the veterinary side, we do have two studies looking at using PEMF, and there may be more, but I did put a few in here. That at least the two ones that come up the most often. Two studies using PEMF for post-op hemilaminectomies. Now, these were not cervical, these were thoracolumbar, but in both of these studies, there was a decrease in pain associated postoperatively with these patients. And in the Zydan study, they also saw an increase in locomotor recovery in these dogs. So we did have evidence that this helped in their recovery with no negative effects, right? So we go to the human side. I actually found a couple, several studies looking at using PEMF for cervical problems. So this one was looking at PEMF on pain, disability, anxiety, depression, and quality of life in patients with cervical disc herniation. It was a randomized controlled study, and they found that patients that were using PEMF had a significant improvement in neck pain, disability, depression, anxiety, and quality of life scores. In compared to those who didn't before treatment. So that was definitely something they concluded could be used safely in routine treatment in addition to conventional physical therapy modalities. And the other study here, they had an effect of PEMF in the treatment of cervical osteoarthritis, and it was a randomized double-blind sham-controlled study. And in this study, they did see that pain levels in the PEMF group decreased significantly after therapy versus no change in the placebo group. And they also saw that range of motion of the neck also improved in the PEMF group with no change in the sham group. So using this again adjunctively with other therapies could be beneficial for cervical osteoarthritis. So we've got evidence on the human side to support this. All right, so what else do we have? So we've talked about PEMF. We also have photobiomodulation, so laser therapy, right? This is working through improving cellular respiration and metabolism, improving and normalizing cellular function, improving ATP production, and decreasing inflammation, improving blood flow, decreasing pain, and improving healing, partially also through induction of increase in nitric oxide, but through a different mechanism than PEMF, right? So this is photons, this is light, and it's a completely different mechanism than what we're seeing with our magnetic field therapy. But we are seeing some similar, some things that are similar when we're utilizing this therapy as well. So when I look at using it, I've used it on these patients, cervical for their cervical pain and inflammation, conservative or post-op. I've also used it on their trigger points. Oftentimes, if these dogs have been down or having issues, they may have skin abrasions, sores, so we can use it on those too. The biggest thing I would say with these is that we need to consider our anatomy when we're utilizing laser. Unlike PEMF, so one advantage with PEMF is, you've got this treatment area. It's the loop as well as the circumference above and below, or diameter above and below the area. So you're treating kind of a wider range during your treatment, and it can also go through, blankets or bandages. Laser, we need for the best penetration and the best results is we need direct contact, and we need to be aiming those photons into the area that we're trying to treat. So we've got to kind of remember our anatomy, which I'll show here in a minute. And then contraindications, we have to be careful of the eyes. We don't want to laser anybody's eyes. So we goggles or covering the eyes ideally, especially if we're near that area. Neoplasia, this is one that's kind of been up for debate on. I list it usually more as a precaution. We don't know. It's mostly because of concern that it might increase growth of a neoplasia. Jury's a little out on that right now. But again, mostly protecting those eyes. And there's a few other things, but these are the main ones. So this is just this one of my patients has chronic neck pain that we were lasering, and so she was in my demo to show kind of how I do this. So depending on the type of laser you have, you will apply it either point to point or you will do it in a scanning mode. This one we were doing in a scanning mode, but either way, I'm showing kind of you're going to want to treat from lateral. Generally, you remember your nerve roots and anatomy nerve roots are coming out laterally. Our cervical spine is lower, the much more muscle on top. And yes, you want to treat the surrounding muscles as well because of those compensatory things. But if we're trying to get those nerves when they're coming out, those nerve roots, lateral is going to be better. And then I angle it a little caudally when I'm getting to the lower neck to try to get back more to that C6 region and beyond to try to get it back in that area. Acupuncture. So acupuncture, another one of my favorite modalities to use for pain, especially because I can use it for pain anywhere, which is great. Decrease pain at every level of the pain pathway. This is going to help locally, segmentally at the spinal cord level and centrally. This is working primarily through the gate theory of pain, asserting that if we give this painful input or stimulus, it's going to close the nerve gate, essentially blocking that ascending transmission of the pain signal to the brain. We also see an increase in endogenous opioid and serotonin, which is great. And we do have evidence in, I don't have the papers here. I didn't have the time to put papers for everything, but we do have evidence to support it helping with cervical disease. Nice thing about it as well is it may actually also modulate motor reflexes at the spinal cord level. So when we're dealing with our our paraplegic patients, that could potentially help. Locally increasing blood flow and circulating stem cells. Ideally, as long as you're not dealing with an epileptic patient, you would use electroacupuncture just for a stronger, longer effect. And we've seen more evidence to support using electroacupuncture if you can, if they'll tolerate it, and you don't have contraindications. I have also lasered acupuncture points in needle phobic patients. I don't know that it's as effective, but at least it is something we can do. And then we can also dry needle or treat those acupuncture or those trigger points with our acupuncture. And this could be painful in some patients, so sedation may be needed, but it's another option. Precaution, mainly just again, electroacupuncture using in epileptic patients. I generally avoid that. And then neoplasia, absolutely can use acupuncture in a neoplastic patient. I just generally don't stick needles really close to the area of the lesion of the neoplasia. If I know there's a cancer there, and I'm going to go other areas instead. But since we're getting central effects and spinal cord level effects, it's still okay that we're not right near the lesion. TENS, so transcutaneous electrical nerve stimulation. Some of you may have used these on yourself, especially when you're dealing with like back pain. This is working through reducing pain again through that gate theory, giving that other stimulus, which acupuncture often is said to have a TENS-like effect, as we're utilizing it that way. It may also stimulate acupuncture points if we have this over those regions. Typically, we can use this in two different ways. So you can apply these little pads to either the nerve roots of for more regional of where you're innervating in the area you want to do. So if you want to do more regional, you can go over the nerve roots that are going to affect that area. Or what I do more commonly is this surround and drown. So covering the area that we're trying to treat and then treating that way with that area. And, these can be used 10, 20 minutes or longer. It depends on the patient, and it depends on how well you can keep those pads on them. Precautions and contraindications, again, epilepsy, neoplasia, so those things of using it right over that site. If you had those type of things are the main ones. Skin abrasions. I wouldn't want to put it right over one of those. Maybe the cool thing is you can teach the owners to do these at home, and they can buy these units pretty inexpensively. So these are definitely another option, especially for some of our chronic pain kids, but even in the acute stage as well. And then this is something we all have, right? You can actually have clear thermotherapy, so ice, heat. Generally, we're looking at using ice more acute, so that post-op area for the first 72 hours, although you can always go longer. This is going to cause vasoconstriction, decreased pain and inflammation. And then once we're past that acute stage, sometimes heat can help us more. So, especially for chronic pain, or if we've got really tight tissues and we're trying to do some passive range of motion and they're really tense, you heat that tissue up first, massage and then stretch and do range of motion. So great to use before massage, passive range of motion, or over maybe massaging some trigger points. That leads us last to our manual therapy. So you don't have to have all the fancy things that way. So you still have to have manual therapies. These are what you can do with your hands is very important. So massage, passive range of motion, especially if we get these patients that are down and they're not moving, we need to do that. Massage is going to relax the muscles, release endorphins, increase blood flow to the area. Also can help with trigger points. Stretching, helping especially with the triceps, those shoulders, and gentling with the neck. We want to treat the tissues of the neck a little gentle, especially if they're painful to start with, but there's things we can do there. I've been doing more and more like kinesiology tape. Instrument assisted soft tissue mobilization can be used for fascial restrictions. Um, One thing is we want to be of care if you do spinal manipulation or are sending patients for that, or you have clients that are doing that, even though you haven't are going to someone. We need to take care when we're dealing with a cervical lesion or lesions of the spinal cord. If we don't have a definitive diagnosis and know the severity, we just need to be careful with that a bit. I'm not saying that that they can't be, and that they can't benefit from mobilization or manipulation, especially downstream in other areas where there's going to be restrictions. But at the site, we have to use some care because there is the potential for making them worse. And then what about shockwave? So last of our modalities that I was going to talk about here. What do we think about shockwave for the cervical spine? So extracorporeal shockwave therapy, most commonly, we're using this for tendinopathies, arthritis, lumbosacral disease, slow healing fractures. So those are kind of my main ones. There's other things, but that's the big one. This is a mechanical stimulation that's then causing increased expression of cytokines and growth factors, leading to decreased inflammation, neovascularization, and cellular proliferation. We also have this cavitation, which decreases pain and inflammation by increasing our cellular permeability. And that cavitation is by the pressure waves that are created by the sound waves when we have that pressure wave increase followed by a negative pressure drop. And that happens with our shock wave. We also see production of free radicals and generation of anti-inflammatory cytokines and growth factors. And then there's been other proposed mechanisms, hyperstimulation of nociceptors, promoting descending inhibition. So again, kind of gate theory, decreasing that pain signaling, reduction of substance P, production of nitric oxide, and increased serotonin activity in the dorsal horn. So these are all ways that we think of shockwave helping. So could that then play a role in our cervical patients? So if we look at the literature, because this is not one that I have tried, so I haven't really thought about it. But when I was looking at this presentation, I was like, oh, could we do this? Would we be in trouble? Would we be problematic? So let's look at the human side. Is there anything to support it on the human side? And they do have a few. I did find a few studies. There was one looking at using ultrasound guided extracorporeal shockwave therapy in patients with cervical spondylomyosis and nuchal ligament calcification. And in those those people, sorry, they did see that they did improve in their VAS scores and with their pain. So they were statistically different in how they were doing with the cervical myofascial pain was improved compared to the group that did not have shockwave. In this next study, they looked at the extracorporeal shockwave therapy on myofascial pain after dissection, and again found improved pain that way, pain relief after using shockwave in those patients. And then looking at clinical evaluation of focused shockwave therapy after with another one with cervical spondylosis controlled trial, they found a reduction in pain, and they did also see some reduction in or improved cervical range of motion in those groups as well. So they were seeing improvements in with shockwave in these patients. So I think it's something to be considered. It's something maybe we should look into more of, is this another option for so if anybody's trying it, I'd like to hear about it. I have not tried it yet, but this is one of the things that piqued my interest about that. All right, so lastly here, because I know I need to wrap up, so we have some time for questions, but I do want to go down to go a little bit over our how we manage these guys in hospital and at home. All right, so we've got the down dog. What are we going to do, right? And this is things that you could use regardless of the cause of your down dog. But when we think of cervical, this guy here, he was a wobbler, did have surgery, and we were working on him here post-op. And you can see we have him up, right? So this is one of the big things. We need to get him up. We have to do our recumbency care. We need to control our pain. We need to improve or at least maintain our tissue flexibility and range of motion. So that's going to be passive range of motion, massage. Generally, I look at, every 4 to 6 hours with that. Supported standing or walking every 6 to 8 hours. Recumbency care in general, so side to side. Getting them into sternal even. Sometimes these guys can't even get into sternal. Part of that because their front legs can be so stiff that they can't bend their elbows to get themselves to sit up. So working on those things with them. And then we'll do gait patterning exercises, weight shifting with them, those type of things. And of course, bladder management is also needed. There's a lot of different things we can use to assist us. We can use harnesses. We need foot protection for some of these guys. We can use physio rolls and peanuts to help get them standing and hold them up because we want to protect our own backs and necks as we're working with these patients. This is a picture of a Hoyer lift. We have one of these. You can get these on eBay. I've actually seen them on eBay. They're from the human side, and they can help with getting these guys around, and they which can be very nice. I've had owners even rent these too. And then we can actually use wheelchairs as well, more from a helping us get the patient up and standing and supporting them for exercises. I'm going to just play one of these videos so you can see how this patient is moving. We're trying to stimulate him to go and get that ball. So he was an unmotivated dog until we found the toys. And so this was a way that we would get him to kind of move a little bit more in this and get him a little bit of activity while we were doing all of his other therapy as well. So here's just some examples of wheelchairs that are got quad carts out there, walking wheels, Eddie's wheels, canine carts, dog on wheels. They all can make quad carts available. And this is something that then can be used in hospital while you're helping them, or this might be something that the owner is going to need to use at home, hopefully temporarily, but maybe in the long term as well if they're dedicated and want to go that route. And then different harnesses. Oftentimes we're going to need, maybe we can get away with just a chest harness because sometimes their hind end starts to work better than their front initially. But oftentimes we going to need a whole system. So there's this buddy up harness, which I don't know if Walking Wheel still makes this, but my go-to oftentimes is the help them up, or I'll use a rough wear front and a help them up back. So a combination of different things. So there's some different options for you that way. If they're knuckling or dragging, we may look at if they've got enough strength to move, but they're just not quite enough to bring those toes up. We can look at some of these anti-knuckling devices to kind of help them retrain and help if they've got that. So Orthopets, Walking Pets has these. There's the Therapaw dorsiflex assist here. You can also use TheraBands to help with gait and retraining and flipping the foot and helping bring that forward. And then, of course, boots, right? So we've got boots or socks. We've got paws. We've got, love it or hate it, paw frictions. Some patients it helps, some it doesn't. Toe grips. So all things to help with traction, but also to protect the feet if they are dragging those feet or scuffing until they're walking better. Lastly, at home considerations, right? We got to get these guys home, and what are we going to advise our owners to do at home? So when they go home, very owner dependent, right? What can the owner do at home? How big is this dog? What is the owner's physical capabilities? What do they have available? And some of that is going to be financial as well. Like you can't keep them in your hospital forever. They need to get home. The owner can't afford to keep them there. So many variables that goes into this, right? We have all the assistive devices that we talked about that we can then utilize at home. They're going to have to do some environmental modification, right? So depending on how ambulatory these patients are, even if they're fully ambulatory, but they're painful in their neck, we're not going to want them running up and down the stairs. We're not going to want them jumping on furniture, right? So they need to be confined, potentially in a smaller space that they can't do dumb things and hurt themselves. You have to block off the stairs, making surfaces that are not so slick, so carpet runners, yoga mats, etc., good bedding. They might be able to need to rent a device, a Hoyer or a wheelchair to assist at home. Bladder management. So big thing if they're not able to do that on their own, of having teaching owners how to do bladder expressions. And there's definitely YouTube videos that you can find that are pretty good out there to help with bladder expression. Passive range of motion videos as well. There's several. We have one here at WSU, so you can always just do, it's a general passive range of motion video of all the joints. So you can even just say go YouTube WSU passive range of motion or passive range of motion, and generally they're going to find some decent videos for them to review, but also you showing them how to do that. Home exercises, sending them home some basic things of assisting them to stand, doing some patterning, weight shifting. We do a bunch of things here, but you can kind of guide them in some of those things of retraining what to do if this are patients that are having ambulation issues. Referral to rehab and acupuncture if it's available, absolutely. I think that's going to be your best if they could do that and the owners can do that. And then a lot of this does depend on if it's a big dog versus a little dog, right? Little dogs are easier to manage in the fact just that they're small, so they're just physically easier to manage that way. Sometimes they're difficult in other ways, but versus big dogs, just the physical, you may have to keep them a little longer just because the owner can't manage them. And that also sometimes dictates prognosis, right? So depending upon what you're waiting for to see how they improve, and the owner wants to wait it out, they may be able to wait out a smaller dog longer than they may be able to wait out a bigger dog, just because of the logistics of caring for that larger dog. So